This is an introduction to some of the common neurologic complications that are seen in the cardiothoracic ICU. These complications are seen not infrequently, and it's important to note that neurologic complications of your cardiothoracic surgery will decrease the likelihood of independence after discharge. This is only an introduction to some of the common neuropathology that we see in the cardiothoracic ICU. It's not an exhaustive discussion, and it's important to note that the Neurocritical Care team is available for consultation on any patient that you're worried about 24/7. So please page the Neurology or Neurocritical Care fellow and obtain a formal consultation. To start with, we'll start with just a case study of a patient that was recently seen in the cardiothoracic ICU. This was a 61-year-old woman with a history of hypertension who underwent an acute repair of a Stanford type A aortic aneurysm. Sedation was lightened about 4 hours after she arrived post-operatively, and nurses noted that she was unable to move her left side. She could move her right side, and she was able to follow commands. Understandably, a CT of her head was obtained, and outlined by the red arrows, you can see a large area of hypodensity, indicative of a large ischemic stroke. And this is what we would call a massive right middle cerebral artery infarction. So ischemic stroke is seen after cardiac surgery. The risk varies depending on the exact procedure that was performed. And it is anything from a routine valve surgery at 3.1% all the way to an 8.7% for aortic repair. These ischemic strokes can be classified as early, or whether or not the symptoms were present on extubation, or late, occurring possibly days after the patient's surgery. When we look at the causes of intraoperative ischemic stroke, they are almost always embolic. And this can be a thromboembolus, a blood clot that dislodges and goes into the cerebral circulation, an atheroembolus, or an air embolus. And any one of these can cause an ischemic stroke. The other type of ischemic stroke that we see intraoperatively is what we would call a watershed or border zone infarction. And this happens when there is already compromised cerebral circulation, possibly from a stenosed carotid or vertebral artery system, and then the patient undergoes significant hypotension intraoperatively, and thus these border zone areas become hypoperfused and cause ischemic stroke. And often with this, you can see what's called a man-in-a-barrel syndrome, where the patient has significantly more weakness in his arms than in his legs. Causes of postoperative stroke are again usually cardioembolic in the cardiothoracic ICU, and these can be due to atrial fibrillation, thrombi forming because of a low ejection fraction, or ventricular assist device associated thrombus. Ischemic stroke should always be suspected in any patient that wakes up postoperatively with new focal neurologic deficits. Anytime there are acute pupillary changes, that raises concern for an ischemic stroke or another acute intracerebral process, or any patient that develops a new onset of focal neurologic deficits at any point after surgery. Just to review the type of imaging that we use to diagnose acute ischemic stroke, CT head is usually the initial imaging modality obtained just because of its ease and rapidity. CT head will not show all ischemic strokes, especially in the very acute period, but it will rule out intracerebral hemorrhage, and it can show medium to large strokes after about 4 to 6 hours. It will miss hyperacute infarcts or very small infarcts. MRI brain is the gold standard to diagnose an acute ischemic stroke, and the sequence that is most used is the diffusion-weighted imaging. What this shows is cytotoxic edema, suggesting that there has been an ischemic stroke, and that's the middle image here. You can see that the area that is bright is the area that has suffered an ischemic stroke, and that the brightness corresponds to cytotoxic edema. Barriers to getting an MRI are frequent, particularly immediately post-op in the cardiothoracic ICU. Patients with retained pacemaker wires are unable to go to the to the MRI scanner. In addition, there are a limited number of MR-compatible pumps available, and often these patients are on a number of vasoactive drips. And so getting an emergent MRI in an immediate post-op patient is often not feasible. Angiography is the other imaging modality that we do, and this is vessel imaging that will show us if there's a large vessel occlusion or whether or not we're suspecting a smaller stroke because we don't see a large vessel occluded. And if you look at the third image on this, you can see that this is an MR angiogram, and you're able to see the right internal carotid artery coming out and branching into the middle cerebral artery. But on the left, you don't see an internal carotid artery or a middle cerebral artery, suggesting this patient has an internal carotid artery occlusion. We also will perform perfusion imaging to show if there is penumbral tissue that remains or if the infarct has been completed. Outside of the cardiothoracic ICU, the mainstay of treatment for acute ischemic stroke is intravenous tissue plasminogen activator, or TPA. And this needs to be given within 4.5 hours of the last seen normal time. Unfortunately, for CT-ICU patients, intravenous TPA is almost never a therapeutic option. Usually these patients' last seen normal is greater than 4.5 hours because usually their last seen normal is preoperative. And then by the time sedation is lightened and their deficits are noted, this time window has expired. In addition, you obviously would not want to give a thrombolytic agent such as TPA to a patient who has just undergone a major cardiac surgery. Endovascular therapy is the other acute therapeutic option for a CT-ICU patient with an ischemic stroke. A patient may be eligible for thrombectomy if their imaging profile is favorable. And a favorable imaging profile suggests that there's a large vessel occlusion on the CT or MR angiogram, which would be amenable to removing the clot. And then there needs to be a perfusion deficit corresponding to this occluded vessel without an evidence of a large infarct already. So if there's a small infarct with a large perfusion deficit, that suggests that there is penumbral tissue able to be saved, and that would be a patient that could possibly go for endovascular therapy. The majority of cardiac surgery patients will not be a candidate for acute revascularization due to extended duration from last seen normal, the nature of their surgeries, and possible hemodynamic instability postoperatively, as well as the difficulty of obtaining timely vessel and perfusion imaging. So the majority of these patients will not be a candidate for acute revascularization. But when in doubt, it is imperative that you call a stroke code. And the nurses are able to call a stroke code overhead. This will get a neurologist at bedside within 15 minutes to do a detailed neurologic exam. It will clear the CT scanner, and it will mobilize nursing resources. And we will be able to evaluate whether or not this patient could possibly have some sort of revascularization procedure. So when in doubt, call a stroke code. Now, very often we see patients in the thoracic ICU. Sorry, I'm going to restart that slide. Occasionally we will see patients in the cardiothoracic ICU that have already suffered a very large infarct by the time their deficits come to attention. And some of these anterior circulation infarcts are sufficiently large that the expected infarct-associated edema afterwards will be life-threatening. And this is termed a malignant MCA infarct. The volume cutoffs are listed on the slide. If we see that greater than 50% of the middle cerebral artery territory on CT is hypodense, or if we get an MRI within 6 hours of symptom onset and the volume of infarct is greater than 82 cc's, or if the MRI is obtained at a later period and the DWI volume is greater than 145 cc's, these are strokes that we would term malignant. Now, with these malignant infarcts, we know that that infarcted tissue will swell over the next few days. And so we will do everything that we can to treat with medical therapy using hyperosmolar therapy and our other medical therapy. But in studies looking at the natural history of malignant MCA infarcts, even with medical therapy, mortality is up to 80%. So the best therapy to deal with this infarct-associated edema is actually a prophylactic decompressive hemicraniectomy. And this requires a neurosurgical consult to remove part of the skull. When we look at the scan of the patient we had initially discussed with the massive right middle cerebral artery infarction, she was taken that evening to the operating room with the neurosurgeons, and you can see that they have removed a large portion of the right side of her skull, and she subsequently developed brain edema with herniation of the brain out through that defect. And this is a life-saving operation because as the brain herniates out of the skull, it is not compressing structures inside the skull and causing a herniation syndrome and death. The important thing to stress with malignant MCA infarcts is that the decompressive hemicraniectomy should be prophylactic, meaning that based on the size of the stroke, you should have a high suspicion that this patient will run into life-threatening edema, so the surgery should be performed before it's an emergency or before the patient begins to herniate. When we look at secondary stroke prevention for patients who have had an ischemic stroke in the cardiothoracic ICU, anticoagulation is indicated for stroke prevention in atrial fibrillation. However, in moderate to large infarcts especially, there is a risk of hemorrhagic transformation of the infarct, so we prefer to wait 1 to 2 weeks prior to initiating anticoagulation, and during that time we will bridge with a daily aspirin. If there is no indication for anticoagulation, meaning that the patient does not have atrial fibrillation or obviously does not have a ventricular assist device or something else that would necessitate anticoagulation, then usually antiplatelet therapy is the secondary stroke prevention drug of choice, and that can be with aspirin or Plavix. If we see significant intracranial atherosclerosis on their vessel imaging, dual antiplatelet therapy for approximately 3 months will be used. Every patient who has had a stroke should be on a statin unless they are unable to tolerate a statin. Blood pressure control is essential, especially as we get into the chronic period. And then these patients will often need physical therapy, occupational therapy, speech therapy, rehabilitation. DVT prophylaxis is imperative for these patients, and often these patients will require a tracheostomy or a PEG tube, depending on how big their stroke was. So shifting gears, we're going to move on to another patient now. This was a patient who was a 52-year-old male with ischemic cardiomyopathy and already had a left ventricular assist device. And approximately 3 weeks prior to his hospitalization at Stanford, he had an acute ischemic stroke at an outside hospital, and this was treated with thrombectomy. He had a recurrent small stroke 3 days prior to coming into this hospital, and then was admitted to Stanford, and due to the recurrent strokes while he was on his left ventricular assist device, he was moved up the transplant list and underwent orthotopic heart transplant. The patient tolerated the surgery well, and per nursing had reactive pupils on returning to the ICU from the operating room. However, when sedation was turned off approximately 5 hours later, the patient was unarousable and was found to have bilateral unreactive pupils. So CT non-contrast was performed, and as you can see, he has had an intracerebral hemorrhage, which itself isn't that small, but he also has a significant amount of diffuse cerebral edema and had herniated. Looking at the characteristic of this hemorrhage, there is a large amount of darkness around the bright hemorrhage. That darkness corresponds to edema, so it's very likely that this was hemorrhagic transformation of his prior infarct. So intracerebral hemorrhage after cardiac surgery isn't common, but when it does happen, it can be devastating. And the risk factors include anticoagulation, both intra and post-operatively. Often patients in the cardiothoracic ICU have an acquired coagulopathy, whether it be DIC, sepsis, or other things. Heparin-induced thrombocytopenia is often seen, as is thrombocytopenia, just from other causes, whether it be sepsis or their ventricular assist device. Recent ischemic stroke is a risk factor, as we've seen with the patient that we just looked at. Hemorrhagic conversion of these ischemic infarcts, especially in the setting of getting anticoagulation, is something that we worry about quite a bit. And then patients with endocarditis with septic emboli are at risk for intracerebral hemorrhage, as are patients with baseline hypertension. Emergent management of intracerebral hemorrhage consists of controlling blood pressure, reversing any coagulopathy that exists, treating raised intracranial pressure if present, and if needed, surgery. Elevated blood pressure has been shown in numerous studies to cause worse outcomes in patients with intracerebral hemorrhage. It's very common after patients have an acute intracerebral hemorrhage, and often these patients are patients who have pre-existing hypertension. The stress and pain of having an intracerebral hemorrhage can raise blood pressure, as well as the body attempting to autoregulate cerebral perfusion in the setting of elevated intracranial pressure. Often the body will bump the blood pressure itself. Elevated blood pressure is associated with hematoma expansion, neurologic deterioration, and poorer outcomes. So we know that we want to lower the blood pressure, but unfortunately the exact blood pressure targets have been elusive in the research that's been performed. There have been two significant recent studies called the INTERACT-2 and ATAC-2 trials, and they both investigated optimal blood pressure lowering after acute intracerebral hemorrhage. Patients were randomized to a group less than 140 systolic and a group less than 180 systolic. In the INTERACT-2 group, there was a small benefit seen in lowering the blood pressure less than 140, but it wasn't a significant benefit. What was proven from these studies is it's likely safe to lower the blood pressure to less than 140 degrees, but it's still unclear what the optimal lowering is. In the cardiothoracic ICU, for patients with acute intracerebral hemorrhage, we usually will recommend keeping the blood pressure less than 140 systolic. Again, this should be taken in the context of patients' cardiac issues. If for some reason, from a cardiac perspective, they needed a higher blood pressure, this could be discussed. For patients with intracerebral hemorrhage who are coagulopathic, the coagulopathy needs to be emergently reversed. Now, if patients have been on a heparin drip, we should discontinue the heparin infusion and then dose protamine based on the amount of heparin given over the past 2 to 3 hours. For patients on Lovenox, protamine can partially reverse this as well, so protamine should be dosed based on how much low molecular weight heparin has been given in the last 8 hours. For patients with warfarin and an elevated INR, there is an emergency warfarin reversal protocol here at Stanford. And this is just a flow diagram. And usually what will happen is case central will be dosed based on what the INR is, with serial checks of the INR and subsequent transfusion of plasma as needed until the INR is less than or equal to 1.4. For reversal of antiplatelet agents, if a patient was on aspirin or Plavix, we will consider giving desmopressin. Often we will transfuse 1 unit of platelets. And for patients with intracerebral hemorrhage, we prefer to have a platelet goal of greater than 100,000 if able. For patients with severe thrombocytopenia, sometimes this is not able, so we will settle for a platelet goal of 50,000. Now, after the acute intracerebral hemorrhage has been discovered, if the patient is neurologically stable and not worsening, often we will repeat a CT scan in 4 to 6 hours to ensure radiographic hematoma stability. If the patient has a very poor GCS felt to be attributable to the intracerebral hemorrhage, then there should be high suspicion for raised intracranial pressure, and measures should be taken to deal with this. And that includes keeping the head midline, keeping the PCO2 35 to 40, and the head of bed at 30 degrees. These patients should not be laid flat or in Trendelenburg. Hypertonic saline with or without mannitol can be given if there is concern for high ICP, and an external ventricular drain can be placed as well. And the neurocritical care team will determine which of these should be performed. It is not routine to perform neurosurgical hematoma evacuation for all intracerebral hemorrhage, but surgical decompression and hematoma evacuation can be considered if there is a large space-occupying hematoma causing life-threatening mass effect. Now, for posterior fossa hemorrhages greater than 3 centimeters in diameter, we will often consider decompression even if the patient is clinically stable due to concern that the subsequent perihematomal edema will cause an obstructive hydrocephalus and brain stem compression. We're going to move to patient number 3 now. This was a 72-year-old gentleman with congestive heart failure, chronic kidney disease, and severe mitral regurgitation. He underwent uncomplicated mitral valve repair via a mini thoracotomy, but subsequently had a very prolonged wake-up and required a Narcan drip. On post-op day number 4, the patient had an episode of rhythmic blinking, facial twitching, and left head deviation for about 1 minute, which resolved spontaneously with no medication. However, due to high concern for seizure, he was treated with Keppra, and subsequently had recurrent episodes of left gaze deviation resolving with Ativan. And he was subsequently also started on valproic acid and a Versed drip. His EEG initially showed right occipital status epilepticus, which improved with administration of his Keppra, valproic acid, and Versed drip. His seizures resolved and subsequently showed periodic epileptiform sharps over his right occipital and temporal regions. The arrows at the right show these epileptiform sharps. So seizure after cardiac surgery has an incidence of up to 7.6%, and it's felt that often non-convulsive seizures are missed, and so the incidence may actually be higher. The causes of seizure after cardiac surgery are numerous. Anything that damages the cortex can cause an epileptogenic area in the brain. It's often seen in ischemic or hemorrhagic stroke. Cerebral air embolism will very frequently cause generalized tonic-clonic seizures. A number of the medications in the ICU can lower the seizure threshold. Hypoxic ischemic injury in the setting of cardiac arrest or prolonged hypotension can predispose to seizures. And occasionally we will have patients who have pre-existing epilepsy who need cardiothoracic surgery, and these patients are at higher risk of postoperative seizure than your baseline patient. In addition, withdrawal is another area where we see seizure not infrequently. So, very basic subtyping of seizure. Generalized tonic-clonic seizure usually consists of a tonic stiffening of the body, followed by rhythmic jerking of the bilateral extremities. We have focal convulsive seizures, where there's often asymmetry of motor activity. This is usually where we'll have head or eye deviation to one side, and you can see progression of the seizure from one area of the body to other areas of the body, or to generalize and include the whole body. Myoclonic seizures are brief shock-like jerks. These are often seen after hypoxic injury from cardiac arrest and often portend a poorer prognosis. However, myoclonus is often seen in the intensive care unit and is not always associated with seizure. So just the presence of myoclonic jerks does not mean that they are due to myoclonic seizures. Non-convulsive seizures often manifest as prolonged encephalopathy in the absence of any other cause. And there may be subtle signs with this, such as nystagmus or twitching, but non-convulsive seizures can be difficult to diagnose. There are numerous seizure mimics that we see in the ICU listed below, so not all the abnormal movements that we see in the ICU are due to seizure. EEG is the cornerstone of diagnosis, especially in the setting of non-convulsive seizures. And usually if we're going to perform continuous EEG monitoring for a patient to rule out seizures, we will obtain at least 24 hours of EEG monitoring, as this has been shown to capture 88% of subclinical seizures. For very high suspicion, we may extend it to 48 hours or longer, as this will increase the yield. In addition, we should always be thinking about the underlying cause of seizure, particularly for patients who did not have pre-existing epilepsy. And usually this includes imaging with a stat head CT. Now, the definition of status epilepticus changed in the last few years, and it now is 5 minutes or more of continuous clinical or electrographic seizure activity, or recurrent seizures without recovery to baseline in between. And the very important point that we want to stress is just because the shaking has stopped does not mean the patient is not seizing. Non-convulsive status epilepticus is seen in the cardiothoracic ICU. So, how to manage a seizure? The emergency management of a seizure first consists of diagnosing the seizure and noting when did it start, the duration of the seizure, and then the features. What were the motor manifestations and the eye manifestations? ABCs are always the most important thing. It doesn't matter how much anti-epileptic medication you give a patient if they're not protecting their airway or are progressing to cardiorespiratory collapse, they won't survive the seizure. So ABCs always. For ongoing seizures, the first line therapy is benzodiazepines with Ativan or Versed. Usually I start with 2 to 4 milligrams and repeat the benzo dose after a couple of minutes if the clinical seizure has not stopped. Second line antiepileptics for ongoing seizures consist of fosphenytoin, valproic acid, or phenobarbital. Keppra is often also used, but in the setting of status epilepticus hasn't been studied yet. There is an ongoing trial at Stanford to compare Keppra with these other medications, but that trial is ongoing. If the patient is in status epilepticus, my recommendation is to use fosphenytoin or valproate. If the patient is having intermittent seizures but is not in status epilepticus, often I will start with Keppra just due to its low side effect profile. If the patient continues to seize despite benzodiazepines and a second-line anti-epileptic drug, we begin to think about suppressing the seizures with an IV infusion. And this can be midazolam, propofol, or pentobarbital. Each one of these medications has their benefits and drawbacks. Midazolam will often see tachyphylaxis the longer that a patient is on it. For propofol, you do run the risk of developing propofol infusion syndrome for prolonged infusions, as well as propofol causing some hemodynamic instability. Pentobarbital is the big gun amongst these three medications. With pentobarbital, once that's being used, you are committing to keeping the patient in a prolonged coma. And pentobarbital has the side effects of significant immune suppression and GI suppression causing ileus. Usually I will start with a Versed drip and increase from there, as well as adding on other second-line antiepileptics such as valproic acid, Keppra, and or phenobarbital. When giving an anesthetic infusion, we will titrate to burst suppression on continuous EEG monitoring. And the image here shows a burst suppression pattern in which there are completely suppressed periods of the EEG where the lines are completely flat, followed by bursts of activity. And usually we'll titrate to burst suppression just to ensure that there is ongoing cerebral activity, but keeping the patient suppressed enough to let things cool down and hopefully have the seizure stop. The Stanford status epilepticus algorithm is outlined here. Priority is to identify the seizure, ABCs, check glucose and other labs. Hypoglycemic seizures will not respond to anti-epileptic medications. The treatment for these is D50, so always make sure to check a glucose on a seizing patient. Benzodiazepines are the first line drugs that we use, and I usually will repeat my Ativan up until I've given 8 milligrams. If the patient is refractory to 2 doses of benzodiazepines, I will usually give them fosphenytoin 20 milligrams per kilogram, unless there's a contraindication of that medication, in which case I will use valproic acid or phenobarbital. Once we get to this point, we will usually connect the patient to EEG. Again, if the patient at any point during this is not protecting their airway, they should be intubated. If the patient has gotten their benzodiazepines and their second line agent with fosphenytoin or valproate, then it's time to start thinking about anesthetic medications such as a Versed or propofol drip with titration to burst suppression on the EEG. And we will also add other adjunctive medications such as Keppra or Vimpat. During this, we are also attempting to obtain diagnostic information, which includes imaging with a head CT, lumbar puncture of suspicion for intracranial infection, and we want to treat the underlying cause. We're going to change gears now and talk about cardiac arrest and therapeutic hypothermia for cardiac arrest. Therapeutic hypothermia has been shown in a number of trials to improve both survival and neurologic function in survivors of cardiac arrest. And the initial trials targeted a temperature of 33 degrees for out-of-hospital VFib VTAC arrests. There was a more recent trial that compared 33 degrees with 36 degrees and found no significant difference between the two. Again, these were performed on out-of-hospital cardiac arrest patients. We've extrapolated this to include in-house arrest as well. So all patients with persistent coma after return of spontaneous circulation, and we define this as no response to verbal commands, should undergo mild therapeutic hypothermia unless meeting exclusion criteria. To be included in our therapeutic hypothermia protocol, this is a cardiac arrest of any rhythm with return of spontaneous circulation and persistent coma after return of spontaneous circulation with no response to verbal commands. Exclusion criteria include any other overt reason to be comatose, pregnancy, or pre-existing DNR/DNI code status. Now, the initial studies targeted a temperature of 33 degrees. However, the more recent targeted temperature management trial showed that 36 degrees was equivalent to this. However, we still prefer a target temperature of 33 degrees unless the patient has a contraindication. And contraindications can include known pre-existing severe coagulopathy, active bleeding, or a condition that increases bleeding risk. And this is because hypothermia below 35 degrees can lead to coagulopathy in patients. If the patient has refractory hypotension, meaning that you cannot maintain systolic blood pressure greater than 90 spontaneously or with low-dose pressors, then the target temperature should be 36 degrees instead of 33 degrees. If the patient has a known terminal illness with a limited life expectancy or severe disability prior to arrest, then hypothermia probably should not be undertaken. And any other condition that in the physician's opinion increases the risk of hypothermia to 33 degrees should be treated with hypothermia at 36 degrees. So we prefer 33 degrees, but if there are any contraindications, they can be cooled just to 36 degrees. Hypothermia should be initiated as quickly as possible, and this is a decision made by the Neurocritical Care team and the primary cardiothoracic ICU team. If for all cases of cardiac arrest with persistent coma, please page the neurology resident or neurocritical care fellow for immediate neurologic assessment prior to paralysis. However, do not delay initiation of hypothermia pending the neurology assessment. And there is a hypothermia after cardiac arrest order set in Epic, and the link to the full targeted temperature management protocol can be accessed through this Epic order set or through the Stanford intranet. For cooling, we will use the Arctic Sun device. It's a surface cooling device. You can see it pictured to the right. The patient has large pads through which cold water is circulated. And the benefit of using the Arctic Sun is that you're able to set your temperature, and the machine will cool or warm the patient as necessary to achieve that target temperature. In addition, we have cooling catheters if the patient has a contraindication to surface cooling with Arctic Sun. These are called the ThermoGuard catheters, and the Neurocritical Care team can assist you in obtaining one of these if needed. Now, if the patient is on ECMO, they can just be cooled with the ECMO circuit. We will set the target temperature and initiate cooling timed for 24 hours. Now, this is the total duration of cooling. It's not 24 hours at 33 degrees. So once cooling is started, the timer starts, and after 24 hours, the patient will be rewarmed. If the target temperature is 36 degrees, you can If the target temperature is 33 degrees, you should paralyze with vecuronium or cisatracurium bolus followed by a drip, titrated to 1 to 2 out of 4 twitches to stop shivering. Shivering will cause significant difficulty in achieving the target temperature and is bad for the patients. So at 33 degrees, we recommend paralyzing the patient for the duration of the cooling. If the patient is only being cooled to 36 degrees, shivering may also occur, so you may need paralysis, but this can be added as needed if the machine is having difficulty cooling the patient or if visible shivering is observed. It is important that all patients who undergo pharmacologic paralysis be put on Versed and fentanyl drips in order to cause amnesia and alleviate any possible pain that they may be experiencing. If there's hemodynamic instability or bleeding occurs at 33 degrees, the target temperature can be changed in consultation with the neurocritical care team to 36 degrees. Bradycardia is common with hypothermia, but usually does not require treatment unless causing hemodynamic instability. All patients will be placed on continuous EEG monitoring for the duration of cooling to look for subclinical seizures, which can accompany cardiac arrest and hypoxic ischemic injury. In addition, we will send a neuron-specific enolase, which we like to refer to as the troponin for the brain, at 24, 48, and 72 hours post-arrest. The neuron-specific enolase is for prognostic purposes only, and an absolute value of greater than 33 has been correlated with poor outcome. Often, the trajectory of the neuron-specific enolase rise will be more prognostic than the absolute value. If the patient is still comatose 72 hours after their cardiac arrest, despite being rewarmed, we will often perform an MRI to look for radiographic evidence of hypoxic ischemic injury. Now, this would consist of diffuse, restricted diffusion, either cortically or in the basal ganglia. As I mentioned, rewarming should begin at 24 hours after the initiation of cooling, not 24 hours after the target temperature is reached. Rewarming per protocol is no more than 0.3 degrees per hour, and the Arctic sun will perform this automatically. Paralysis, if being used, should be discontinued after the patient has been rewarmed to 36.5 degrees. And after discontinuation of the paralytic, and once we have return of the train of fours, all sedation should be discontinued to allow the patient to wake up. We recommend maintaining the temperature with the Arctic sun at 37 degrees for another 72 hours to avoid fever, as this has been shown to cause worse outcomes post-cardiac arrest. And continue to treat shivering during rewarming. There is a shivering order set in Epic. Prognosis after cardiac arrest has become increasingly difficult in the era of therapeutic hypothermia. And usually it's a composite of the clinical exam, any negative EEG patterns that were seen, neuron-specific enolase, MRI findings, and or somatosensory evoked potentials. An increasing number of patients in the post-therapeutic hypothermia era have reported good outcomes despite having findings that were previously thought to be very poor prognostic signs, such as myoclonic status epilepticus. When the prognosis is unclear, often we will give the patient time to see if they will wake up. The last subject we're going to talk about today is spinal cord infarction. These are seen not infrequently in the cardiothoracic ICU, usually after extensive aortic procedures. Usually this is noticed after the patient awakes from surgery, and the patients will usually present with an anterior spinal artery syndrome. And what an anterior spinal artery syndrome consists of is bilateral lower extremity weakness, loss of pain and temperature sensation below the level of the lesion, preserved proprioception and vibratory sense, a spinal level on the torso, and autonomic dysfunction. Risk factors for spinal cord infarction. Starting the slide over. Risk factors for spinal cord infarction include a long extent of an aneurysm, hypotension, whether or not the procedure was emergent, an acute aortic rupture or aortic dissection, long duration of aortic cross-clamp, failure to reimplant segmental arteries, prior distal aortic surgery, and severe peripheral vascular disease. When we look at the vascular anatomy of the spine, the anterior 2/3 of the spinal cord is supplied by the anterior spinal artery, which comes off of the vertebral arteries and is fed by radicular arteries originating off intercostal arteries as it proceeds down the chest. The most prominent radicular artery is at about the level of T9, and it's the artery of Adamkowitz. And the anterior spinal artery supplies the corticospinal tracts and the spinothalamic tracts, explaining why when somebody has an anterior spinal artery occlusion, they will develop bilateral lower extremity weakness as well as loss of pain and temperature sensation. The posterior third of the spinal cord is supplied by the paired posterior spinal arteries. These supply the dorsal column medial meniscus pathway, and this explains why for an anterior spinal artery infarct there is preserved proprioception and vibration sensation. Now, the anterior spinal artery is more susceptible to infarct given that it's a single artery, whereas there are two posterior spinal arteries. In addition, the anterior spinal artery receives much less collateral flow from the radicular arteries off the intercostals. The mid-thoracic region of the spinal cord is the watershed region where the perfusion to the cord is the worst, and so this is the area most susceptible to ischemia. The diagnosis of spinal cord infarction immediately postoperatively is usually clinical. It can be confirmed radiographically with an MRI showing restricted diffusion in the spinal cord. It's important to note that if you're going to order an MRI at Stanford to look for a spinal cord infarct, it must be ordered specifically with a DWI sequence, as this is not routinely done for spinal MRIs. The MRI will also help to rule out other etiologies of lower extremity weakness, such as transverse myelitis or a compressive myelopathy. The problem is that often our cardiothoracic surgery patients are not able to get to the MR scanner immediately post-op for the reasons discussed previously, in that they may still have pacer wires still in place or not be hemodynamically stable to go for a scan. Therefore, the diagnosis is often clinical. Treatment of spinal cord infarction. Spinal cord infarction can be associated with hypotension or bradycardia. However, these are usually associated more with high cervical injuries, which are seen less commonly in aortic surgeries. Lumbar drainage is a mainstay of treatment of spinal cord infarction. Often the lumbar drain will be placed pre-op for large aortic surgeries. However, if there was no lumbar drain placed and there is a suspicion for spinal cord infarction, one should be placed. CSF is drained at no more than 10 cc's per hour, as draining more than this causes a risk of intracranial hypotension and subdural hematoma. The other thing that we will do to treat spinal cord infarction is we will augment the blood pressure. The exact blood pressure goal isn't clear, but we will usually try to keep the MAP greater than 80 to increase spinal perfusion. And that's an extrapolation from some of the post-spinal cord trauma literature. The theory behind lumbar drainage and augmenting the blood pressure is shown by the formula below, in that the spinal perfusion pressure is a function of the mean arterial pressure minus the lumbar CSF pressure. So we want to increase the mean arterial pressure and decrease the lumbar CSF pressure to increase our spinal perfusion pressure. Just another plug for Stanford Neurocritical Care. We are always available to help with all of the issues above and should be consulted for any of these issues. The Neurocritical Care resident or fellow can be paged to the operator, and we are happy to help with any of the patients that you need help with.